Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is surgical management of postpartum hemorrhage, the stepwise devascularization. PPH remains major contributor for maternal mortality. Speedy diagnosis and management saves lives. Uterine sparing surgical procedures save uterus as well as lives. And it is a must know area and it must know surgical procedures, we should say, for each and every obstetrician to understand and to perfectly know what are the steps to practice and to master all these procedures so that you save lives as well as you save the uterus. Uterine balloon tamponade is considered as first surgical intervention for atonic postpartum hemorrhage as per Green Top Guideline 2016 RCOG guideline, and it has been given that it has given that it has 80 to 90% of the success rate. It has a special value in low resource settings, use of your uterine balloon tamponade, and many of you must have seen it being used or must have used it yourselves. It is considered as mechanical method by other authors or other publications. Tamponade test, it is called as a tamponade test, and it is used to assess the need of surgery. Tamponade test is first you use this uterine balloon tamponade, and if it is effective, then there is no need for any further intervention. In case there is no response and there is persistence of bleeding, then it is an indication to proceed with other surgical interventions by doing laparotomy. Various tamponade methods are by with the use of condom catheter if other devices are not available, Foley's catheter, Bakri balloon, sense taken, Blackmore esophageal catheter. All these have been used, and this can be used with even at the low resource settings. Also, we can use condom catheter, and we can have the effective way of having a tamponade or pressure or compression over the uterus, especially over the placental bed, which leads to the arrest of bleeding. This balloon tamponade needs to be kept for 4 to 6 hours and it is removed preferably in the daytime, so that if there is recurrence of bleeding, we can proceed with other procedures with the better availability of all the resources. Now, available surgical options whenever there is a postpartum hemorrhage and patient is not responding to medical management. One side we have uterine sparing procedures and on the other side we have hysterectomy. In the uterine sparing procedures, we can divide these procedures in two main groups as vessel ligation procedures and compression sutures. Coming to vessel ligation procedures, the most famous is the O'Leary's bilateral ligation of uterine arteries. Second is triple ligation, which was introduced by Cyrulnikov's triple ligation. Then comes stepwise uterine devascularization, which was introduced by Abd-Rabo. So it is also called as Abd-Rabo's stepwise uterine devascularization. Success rate of all these together has been documented in the literature as around 90%. Next is internal iliac or hypogastric artery ligation. It is relatively technically difficult as compared to these procedures. It has a success rate of around 70%. It has low rate of complications, but whenever a complication occurs, usually it is a serious complication. So same we can say in a flow chart manner that vessel ligation on one hand, we have internal iliac artery ligation. On the other hand, we have uterine artery ligation, triple ligation, and stepwise devascularization. Now let us understand the unique blood supply of the uterus so that it helps us to understand the procedure better. This is the uterine artery, which is a branch of internal iliac artery, and it comes to the uterus at the level of the isthmus or at the level of the internal os of the cervix, and then it divides into two branches. A smaller branch is descending cervico-vaginal artery, which supplies mainly the cervix and vagina, whereas main artery continues by taking a swift turn in upward direction, and it is the ascending uterine artery, and it supplies the uterus by sending multiple branches of arteries which are called as arcuate arteries. And these arcuate arteries from both the sides, they are traversing through the submucosal layer in the myometrium, and there is a rich anastomosis of these arcuate arteries in the midline. So a one-sided arcuate artery has got it gets anastomosis with the opposite sided arcuate artery on anterior surface of uterus as well as posterior surface. So that is how there is a rich anastomosis between the vessels of both sided vessels of the uterine arteries. Then this arcuate artery goes till the fundus, and then there it continues as the round ligament artery. And when it comes to the cornu, it is sending off three terminal branches. So the three terminal branches of this ascending uterine artery at the cornu first is a fundal branch, which is supplying the fundus of the uterus. Second is a tubal branch, which is supplying the fallopian tube. And third is the ovarian branch, most important, which is anastomizing with the ovarian artery. So this is the ovarian artery, which is a branch of aorta. It supplies the ovary at the hilum of the ovary, and then it continues towards the uterus and gets anastomized with the anastomosis occurs with the ovarian this ovarian branch of the uterine artery, and that is how this ovarian artery and uterine artery have got a rich anastomosis here. So rich anastomosis is between arcuate arteries in the midline, as we have already seen, and there is an anastomosis between uterine artery and ovarian artery also. These arcuate arteries, as they supply the myometrium, they send off the radial branches. Radial branches are piercing the myometrium and reaching up to the endometrium. At endometrial layer, basal arterioles are supplying the basal layer of the endometrium, whereas spiral arterioles, as we all know, are important branches which are arteries, spiral arterioles, which are mainly supplying the functional layer of the endometrium. So this is in short about the unique blood supply of the uterus, with special emphasis on where the various levels where there is a rich anastomosis between the vessels supplying the uterus, and that is how the uterus is always has a better result even after the injury, any, or even there is a trauma, there is a cesarean section scar, we do any surgeries on the uterus, the healing is better because of this capacity of the uterus to restore its blood supply because of the presence of this rich anastomosis. Now, this bilateral uterine artery ligation, that is the first procedure. Let us start understanding this. It was introduced by Watters in 1952, but it has mainly been popularized by O'Leary, and that is why it is called as O'Leary's bilateral uterine artery ligation. Watters' introduction of this procedure was based on the main understanding of the fact that uterine blood flow reduction is by 90% when bilateral uterine arteries are ligated, whereas there is 40% reduction when we do the internal iliac artery ligation, and that is why he thought that it will be more efficient way of arresting the bleeding in postpartum hemorrhage as compared to internal iliac artery ligation. Ligation, what is done in this is ligation of ascending branch of uterine artery with the associated venous plexus is done when we do this procedure of uterine artery ligation. Mainly we are ligating the ascending branch. What are the steps of the procedure? First, most important is exteriorize the uterus, bring it out of the incision. Assistant should pull the uterus upwards and to the contralateral side to prevent ureteric injury. This is important that assistant has to pull up the uterus and has to um, pull it towards the contralateral side so that the uterine artery is kept away from the ureter, and we don't include the ureter when we are ligating the uterine artery. Then one has to open the uterovesical fold of peritoneum, and we have to push the bladder down by 3 to 4 centimeters and keep the bladder protected by introducing a retractor. Then what has been given in the description in the mainly in the standard literature is clamping and ligating the round ligament is optional step, and it has been advised mainly for beginners. So that once what happens is when we this clamp and ligate the round ligament, what and cut it, what is happening is it opens the two leaves of the broad ligament. Anterior and posterior leaves of the broad ligament get opened up when we open the this clamp and cut the round ligament. That is why it helps in better understanding of the anatomy in the brown ligament itself. That is why it has been suggested that beginners can do this step. Once you know the technique and you master the technique, then you might not be doing this step of clamping and ligating the round ligament. Now, with finger behind the broad ligament, we have to identify the uterine vessels. Uterine vascular plexus can be identified when we put our finger behind the broad ligament. So, through light, we can see the vessels. Then we have to identify the avascular area in the broad ligament, and we have to create a window. Window should be created of 3 to 4 centimeters. Either we can use electrocautery to create the window, or even with the manually also, because it is a transparent area, no vessels are there, and it is easier even with the finger also to create this window. So we have to create the window with the use of electrocautery or manually, and the size of that window is around 3 to 4 centimeters. But as you become more experienced, you can reduce this size of the window. It can be narrower with the experience. This window is lateral to the uterine vessel. Window creation prevents ureteric injury, as we can see here. Now once you put open the uterovesical fold of peritoneum and push the bladder down, ureters go laterally. So ureter is already here laterally present like that. Uterine vessels are in proximity to the uterus, and we are creating a window in the avascular area so that when we pass the needle, it doesn't pierce any vessel and there is no broad ligament hematoma formation. Pelvic hematoma formation is prevented. And secondly, it protects the ureter also, because we are going through transparent area where there are no vessels, there is no thick structure similar to the ureter also. So this is important step, creation of the window. After that, we have to take a we have to ligate. Ligature is to be taken by using absorbable suture. Delayed absorbable suture can be used, and we have to pass the needle through this window, and we have to pierce the uterus posterior to anterior, so that when we go posterior to anterior, it avoids the possibility of bowel injury. And then we have to put a knot here, ligate on the uterus, on the uterus ligation, so that the knot remains stable here rather than knotting in the window. So that is how we have to ligate. The depth of the suture should be deep in myometrium, but it should not be entering the uterine cavity. So it has to be deep but not too deep. It should not be entering the uterine cavity, but through myometrium we have to take a deep bite. Where we are taking the bite, it is 2 to 3 centimeters below the incision, caesarean section, lower segment caesarean section incision. Below that, 2 to 3 centimeters below that, we are taking this bite. It is called as a high, this is now upper one is called as a high ligation suture. High ligation is, first suture is 2 to 3 centimeters below the caesarean section incision. Second, we take to occlude the cervico-vaginal branch or descending branch, and it is 2 to 3 centimeters below the high ligation suture. So double ligation is done. That is more effective as compared to taking only one suture, which is ligating the ascending branch of the uterine artery. We should be ligating this ascending branch as well as this cervico-vaginal branch, so that it helps in the uh, control of the hemorrhage in a more effective manner. That is why this high ligation along with the low ligation is advocated. HL is high ligation suture, absorbable suture from posterior to anterior to avoid bowel injury. Site is 2 to 3 centimeter below LSCS incision. Low ligation is 2 to 3 centimeters below the high ligation suture. It is taken to occlude the cervicovaginal branch. Suture should be deep in the myometrium but should not be entering the uterine cavity, not should be on the uterus. So why bladder dissection is necessary before uterine artery ligation is this diagrammatically I want you to understand this. What is happening here is this is the utrovesical fold of peritoneum which contains bladder. Yellow part is the bladder which is present in utrovesical fold of peritoneum. This is the uterine artery which is piercing the myometrium, and just 2 centimeters lateral to the internal os or isthmus, uterine artery crosses over the ureter. So they are in close proximity to with each other, this ureter and uterine artery, and that is the reason we have to take this step. What we have to do is we have to open the utrovesical fold of peritoneum, push the bladder down. When the bladder is pushed down, as you can appreciate here beautifully, ureter ureters are going away from the uterine artery. They fall laterally. Ureters go laterally as the bladder is pushed down, so that this proximity of the ureter and uterine artery is no more present. And when we take the uterine artery ligation, as you can understand here, because of this important step, ureter is never getting uh, involved, or we are not going to do the ureteric injury whenever we are doing the uterine artery ligation, because now ureters are running quite laterally, and this that is why this is important step. Bladder dissection and pushing the utrovesical fold down, pushing the bladder down is important, especially whenever it is a case of previous cesarean section where there can be a possibility that bladder is adherent over there. So we have to do a sharp dissection and push bladder down. Then the ureter falls laterally, and there is no risk of going for a bladder injury or either for a ureteric injury when we do the uterine artery ligation. So important precautions during uterine artery ligation to prevent all the complications, ureteric injury, bladder injury, pelvic hematoma are: push bladder down, especially with previous cesarean section, and protect the bladder by keeping a retractor, bladder retractor. Assistant should be pulling the uterus up and to the opposite side so that the ureter again there is a distance gets created, greater distance gets created between the ureter and uterine artery. Create a window in the broad ligament at avascular area. After palpating the uterine vessels, lateral to the uterine vessels, we have to create a window in the avascular area so that needle does not pierce any vessel. There is no formation of a pelvic hematoma, and that window creation also helps in prevention of ureteric injury. Advantages of this uterine artery ligation: it is a simple technique. It has been seen that even at the residency level also this technique can be, we can learn this technique. So relatively it is simple technique. We can perform it rapidly, quick, which is the procedure is doesn't is not very time consuming, which is of most importance in a case such as postpartum hemorrhage where patient is bleeding profusely and minutes are even seconds are important. And so whenever any procedure we can do which is rapid, which can be performed rapidly, it will prove to be time consuming as opposed to a procedure which will be if it is more time consuming, then even if you do the procedure, by that time patient might go in irreversible hemorrhagic shock. So we need any procedure which can be rapidly performed, and this procedure fulfills this criteria in the important steps in the management of postpartum hemorrhage. It efficacy is around 90%, which has been quoted in the literature. Now, even if it is not effective in say 10 to 15% of the cases, it is not effective. Still, we have to patient becomes hemodynamically unstable. We have to take a decision to proceed with hysterectomy. Still, this procedure is a part of hysterectomy. So there is no delay in the hysterectomy decision with hemodynamic instability, because this step is necessary even if we proceed with hysterectomy also. So that is another advantage of this uterine artery ligation. It has no ill effect on subsequent pregnancies. It has been so many case reports and case series are available where the surgeons have done this, obstetricians have done this, and even subsequent pregnancies also there are no problems, there are no disadvantages. Complication which is reported is retroperitoneal hematoma in 1%. And as I said, if we create a window in avascular area and if we carefully pass the needle posterior to anterior, retroperitoneal hematoma formation complication risk will be less. But still remember that that has been quoted as one of the complication. Indications are any obstetric hemorrhage because of laceration of uterine hysterotomy incision. You are doing a cesarean section so many times, there is there is angle extension of the incision in upward direction, downward direction, laterally towards the broad ligament. We all encountered all these problems during cesarean section, especially whenever it is a cesarean section which is done late in labor. Lower uterine segment is excessively stretched, or there is obstructed labor. For some reason, there is difficulty in the delivery of the baby. In all such situations, this risk of lacerations at the lateral lacerations increases. Laceration entering into the going towards the broad ligament and involving the uterine artery also. So for such cases, this uterine artery ligation is most effective. It can also be it is also indicated whenever there is a atonic postpartum hemorrhage and abnormal placentation. Now, abnormal placentation, remember, it includes two entities. One is placenta previa and other is morbidly adherent placenta. So placenta adherent placenta, all the varieties of placenta percreta, increta, or accreta. It is called as placenta accreta syndrome, or including all accreta, percreta, increta, and percreta. So all these are included under abnormal placentation, and there is more and more evidence that this uterine devascularization plays important role even in such difficult cases. It can be done as unilateral procedure or bilateral procedure, though the procedure which was described by O'Leary was bilateral uterine artery ligation, where he also recommended high ligation along with low ligation. Now, second technique is called as triple ligation technique, which was introduced by Cyril Nico in 1974. Three sutures are taken. What is done is a high ligation uterine artery bilaterally ligation, uterine artery ligation on both the sides as high ligation. High ligation is mainly the we are ligating the ascending branch of the uterine artery by taking a suture 2 to 3 centimeters below the incision of the caesarean lower segment caesarean section uh, site. So this is high ligation uterine artery ligation on both the sides as number one. Number two is round ligament ligation on both the sides. Now this is round ligament ligation. The rationale is it is the rationale behind doing this round ligament ligation is there is a thinking that round ligament artery also has anastomosis with the branch of the ascending uterine artery which is continuing as the round ligament artery, and to prevent this supply from the round ligament artery, this round ligament ligation is done. Third is ligation of utero-ovarian ligament, which includes the ovarian artery, which it is also done on both the sides. So 1, 2, 3 on both the sides similar. So that is why it is called as triple ligation. Number one is high ligation uterine artery. Number two is round ligament ligation. Number three is utero-ovarian ligament ligation along with the underlying ovarian arteries. Rationale is why we are doing including this ligation of uterovarian ligament is in 4% of the pregnancies, ovarian arteries contribute to placental perfusion and perfusion as major vessels. So in these 4% of the pregnancies, even if you do uterine artery ligation, bleeding from the placental site will be persistent, because in these cases the major supply uteroplacental blood supply is by this ovarian artery, and that is why there is a need to go ahead with the uterovarian ligament ligation. Round ligament ligation, there is no evidence to support it, but it was advocate. It has been included in this triple ligation. Success rate, which has been quoted by various researchers, is around 75%. Now we come to stepwise uterine devascularization, which was introduced by Rabo in 1994. Rabo in 1994. It was introduced by Rabo et al. They publish a report of efficacy of this stepwise uterine devascularization, where in their series the efficacy was 100%. What is done here is progressive uterine devascularization. Next step is done only if there is no arrest of bleeding after 10 minutes of the wait. So you do step 1, wait for 10 minutes, persistence of bleeding, then do step 2. After step 2, you wait for another 10 minutes, persistence of hemorrhage, then only you go for step 3, and so on. So that is why it is called as stepwise uterine devascularization. We have seen bilateral uterine artery ligation, where we do the high ligation, low ligation on either one side or both the sides. But triple ligation, we do simultaneously three ligations at 3 points. But here the concept is different. In stepwise uterine devascularization, we are waiting for 10 minutes. And if step 1 is effective, there is no need to proceed with other steps, mainly because we do not want to do the drastic devascularization of the uterus, so that there is no risk of uterine necrosis in rare cases. Though it is rare, that is a complication which has been reported as a rare complication, and we do not want to do the unnecessary invasive surgical procedures with its possibility of increasing complications. And that is why the stepwise uterine devascularization as a surgical concept is safer as compared to going directly with the bilateral uterine artery ligation or with the triple ligation. What is done is step 1 is unilateral high ligation of uterine artery, which is done 1 centimeter below the LSCS incision. So this is step 1, high ligation. Wait for 10 minutes. If there is persistence of bleeding, then you do high ligation on the opposite side, contralateral high ligation. Step. Wait for again 10 minutes. Persistence of bleeding, you do bilateral low ligation. So low ligation is on both the sides. Step 3 is you do the take a low ligation suture or ligation of the descending branch of the cervicovaginal branch of the uterine artery on both the sides. That is step 3. Step 1 is one side, step 2 is opposite side of high ligation, step 3 is both sided low ligation. Now there is a question mark about step 4 and step 5. Rabo, they describe in their initial paper, where they published the paper, that they proceeded with the unilateral ligation of ovarian vessels as step 4, contralateral ligation of ovarian vessels as step 5. But question mark is there because there is a confusion whether they did the ovarian vessel ligation at the infundibulopelvic ligament or suspensory ligament of the ovary, or whether they did the ovarian artery ligation at the utero-ovarian ligament, whether it was done medial to ovary or lateral to ovary. The main confusion or main concern, as you can understand, if we ligate the uterine vessel here, we are also reducing the blood supply to the ovary, so that all the complications of premature menopause affecting the future fertility are likely to be present if the ovarian artery ligation, vessel ligation is there done in the infundibulopelvic ligament or suspensory ligament of the ovary. They just mention ovarian vessels, but if ovarian vessels supplying the ovary are ligated, these ovarian vessels which are present in the suspensory ligament of the ovary, chances of ovarian failure as a complication is there. Future fertility might be hampered, and even studies have done, was researchers or surgeons, obstetricians, they proceeded with the the ligation of ovarian arteries in the suspensory ligament as a step in stepwise devascularization, and in 30% of the cases future fertility was hampered and patients had ovarian insufficiency. So if we ligate the your ovarian vessels in utero-ovarian ligament, there is no such danger to the ovarian blood supply, and that is why recommendation, the current recommendation as per the expert review article 2024, there is an important review article which is available, which was published in American College of Obstetrics and Gynecology Journal in 2024. And that, according to the experts there, they also tried with this ligation of the ovarian vessel in utero-ovarian ligament. They are recommending that we should be ligating. Step 4 is ligation of one-sided utero-ovarian ligament as step 4, and if there is after 10 minutes persistence of bleeding, then only we go for contralateral side, opposite side ligation of ovarian vessels by ligating the utero-ovarian ligament, as we call it as a ovarian ligament. And from cornus, three structures are arising. Anterior most is the round ligament, middle is the fallopian tube, and posterior most is this ovarian ligament or utero-ovarian ligament. So when we ligate this utero-ovarian ligament along with the vessels which are present below it, we are ligating the ovarian arteries or ovarian vessels. So this is step 1, high ligation of uterine artery on one side. Step 2, high ligation of uterine artery on contralateral side. Step 3, both sided low ligation of uterine artery. Step 4, ligation of utero-ovarian ligament with the underlying ovarian vessels. Step 5, opposite-sided ligation of utero-ovarian ligament with underlying ovarian vessels. These are the 5 steps in the stepwise devascularization. Now, why there is no uterine necrosis after uterine artery ligation? Because of the extensive collateral circulation of the uterus. As we have already seen previously, there is a midline anastomosis of arcuate arteries. There is rich anastomosis between uterine and ovarian arteries. Along with that, even hormonal levels and this presence of inflammatory markers also do play some role in the revascularization of the uterus. But there is a usually there is effective or successful revascularization of the uterus even after bilateral uterine artery ligation. Necrosis is a rare complication. Risk of necrosis is more. This is important point. If uterine artery ligation is combined with tight compression sutures. If these two are combined, compression sutures and uterine artery ligation, risk of necrosis is greater. Necrosis can occur with rare anatomical variations in uterine circulation. Some patients can have anatomical variations, so anastomosis is not that efficient, and these are the cases rarely there can be the necrosis because of this reason. Risk of necrosis is comparatively more after uterine artery embolization than uterine artery ligation. Coming to internal iliac artery ligation, here uterus is pulled forward and to the opposite side. Posterior peritoneum is opened over the common iliac artery. This is aorta which divides into common iliac arteries, and then common iliac arteries are dividing as external iliac and internal iliac. This is the retroperitoneal anatomy which we all know. This incision is given over common iliac and then it is extended down for 4 to 5 centimeters. Internal iliac artery is identified and it is dissected from surrounding tissue. Non-absorbable suture is passed from lateral to medial. When we go lateral to medial, the danger of injuring the internal iliac vein is not there. There is otherwise there is a vein is there present here, and it can get, there can be a trauma to the external iliac vein. Internal iliac vein also can get traumatized, and to prevent that we have to go always from lateral to medial. This direction is most important, where we are going below the beneath the artery from lateral to medial side, and then suturing it over it. Knot is tied. Where this knot is not ligation to be done, it should be done 2 centimeters distal to the origin of interiliac artery, so that the posterior branch is not included. Posterior branch of the interiliac artery is spared. Technically, this is comparatively difficult. Success rate of the procedure which is documented is 60 to 70%. But though rare, the serious complications can occur, such as ureteric injury, external iliac vein injury. Here there is an external iliac vein, and that is why we are going from always from lateral to medial, not to pierce the external iliac vein which is lying here. Ligation of external iliac artery by mistake. I have heard that one patient had to undergo amputation because the obstetrician by mistake ligated external iliac and not internal iliac. Always after doing the interiliac ligation, we have to confirm that there is presence of dorsalis pedis pulsations. That is mandatory. We have to see that we are not ligating, or femoral pulsations, we are not ligating the external iliac artery. We have to be very, very careful. And why we should listen to all these stories of complications is for us as a learning lesson, that any procedure we do, we should be most cautious, because we are playing with the life. Imagine a life after amputation for a young woman who has to look after her baby also. So that is also one of the documented complication, ligation of external iliac artery and gluteal claudication, which is also producing a lot of morbidity. So whether to do the proceed with uterine artery ligation with a torrential postpartum hemorrhage, or we have to we should directly go for interiliac artery ligation. There are no randomized control trials comparing these two procedures. It depends on operator's experience. Especially for the interiliac artery ligation, we need experienced obstetrician, or a person who is like gynec oncologist or oncosurgeons, who are on a routine basis dealing with the retroperitoneal anatomy to prevent the occurrence of complications. Uterine artery ligation is technically easier to learn as compared to internal iliac ligation. That doesn't mean that those who are doing internal iliac artery ligation are doing something wrong. It is mainly the operator's experience which decides whether to go ahead with uterine artery ligation or stepwise devascularization or internal iliac artery ligation. Now we come to the second part of the surgical procedures, which are uterine saving, which are saving the uterus, and uterine compression sutures forms the important component of these procedures. Here we are what we are doing is plication of the uterus by approximating anterior and posterior walls. Pressure is exerted mainly over the placental bed. So there is opposition of anterior and posterior wall, which produces pressure over the bleeding placental bed, and it helps in the arrest of further bleeding. And compression sutures are most effective in atonic postpartum hemorrhage. B-Lynch compression suture, it was introduced by B-Lynch in 1997. Here what is done, it is called as like, it is like a brace. So mediolateral brace suture. Other way of calling this B-Lynch suture is also called as brace sutures. Mediolateral brace sutures, two sutures and on two sides. Initially, B-Lynch used number 2 chromic catgut, and there was in the process the procedure also which was described needed hysterotomy. That means cesarean section, or even if you do it without cesarean section, opening of this lower uterine segment was a necessity in the original B-Lynch procedure. But now B-Lynch himself is advocating use of monofilament suture rather than the chromic catgut. and it can be done now without hysterotomy also. It can be done by using a hand needle or a large round body needle. Pre-procedure bimanual uterine compression is used to judge likely efficacy of the procedure. That means before doing this B-Lynch compression suture, you compress manually, bimanually you compress the uterus by opposing the anterior and posterior walls and giving compression over mainly over the bleeding area in the uterus. Usually it is the placental bed if it is atonic postpartum hemorrhage. And if that leads to the arrest of bleeding, that gives you the idea about the possibility of success of this procedure. What is done is here, as I have shown here, number one is here, from here the suturing starts. The needle goes in and comes out here at number two, above at the superior margin of this hysterotomy incision. Then you just go around the fundus on one side, mediolateral side, and come back just medial to the number 2 point as number 3 through the posterior wall of the uterus. Go back through posterior wall, pierce the posterior wall again, go posteriorly, come back anteriorly at 5, number 5, and then at number 6, and ligate 1 and 6 together. So this, it is recommended by RCOG that laminated diagram of this B-Lynch should be available in each and every operation theater, so that there should not be any confusion in emergency, and it leads to quick this B-Lynch suture uh, the procedure, and not wasting the unnecessary time. This is the original one, but now B-Lynch is now even is advocating the modification where hysterotomy is not necessary. Cho compression suture was introduced in 2000. Here, in this, there is use of multiple transfixion sutures. What is the meaning of transfixion? Remember that needle goes through and through from anterior serosal surface to posterior serosal surface. So when we are going through any tissue through and through, it is called as transfixion sutures or transfixation sutures. So use of either multiple transfixion sutures or multi-stitch square sutures. Cho compression sutures are multi-stitch square sutures. Say this is the bleeding area. You start at point 1. The needle is piercing through and through from anterior to the posterior wall of uterus. It is coming out at number 2. Needle comes out at point number 2. Then you go to number 3 and again pierce the uterus from posterior to the anterior to the posterior wall. Come back from posterior to anterior here, and then you ligate number with the suture which is present at point number 1. So 1, 2, 3, 4 are the 4. So like that we create square sutures. That square sutures are Cho compression sutures. Even if it is the bleeding from the placenta previa, placental bed which is present over the lower uterine segment, then also it is very highly effective when we take these square sutures like that through and through from anterior to the posterior. You come from posterior to anterior to posterior, you go at number 1. Posterior to anterior you come at 2. Again anterior to posterior you go at 3. Posterior to anterior you come at 4, and then ligate. Like that we are creating the square sutures. Straight needle with number 0 polyglactin 910 suture is used. 4 suture points are taken around bleeding area. Sutures go through and through from anterior to posterior mucosa and come back from posterior to anterior. It is useful in uterine atony, and it is useful in diffuse bleeding such as in placenta previa. It is at present most popular compression suture. It is more popular, it has been mentioned in literature, it is even more popular than B-Lynch suture. There are so many modifications of these compression sutures. Heyman modified this B-Lynch suture by taking two separate mediolateral sutures without the need for hysterotomy. Even if you have closed this cesarean section incision, closed hysterotomy, there is no need to reopen it. And we have to, what is done is we have to go through and through from anterior to posterior, and we have to ligate at the top like that. Knot is at the top, and the Heyman recommended either you take two sutures on each side, or we can take one on each side. So either two on each side, original hymen, or modification of hymen is taking only one on each side. Heyman, Cho, and B-Lynch are transfixion sutures. Again, I am repeating the definition of transfixion is needle is passing from one anterior serosa to the posterior serosa throughout whole of the myometrial thickness and coming starting from one serosal surface to the anterior serosal surface to the posterior serosal surface. So all these Heyman, Cho, and B-Lynch are transfixion sutures passing through and through the anterior and posterior uterine walls. Now, another important instruction is assistant has to manually compress the uterus before tying any of the compression sutures. This is most important. Otherwise, the sutures will not be effective. Assistant has to manually compress the uterus, compress it as much as possible, so that the sutures are tight and the opposition of anterior and posterior walls is effective. So many other modifications are there, and one more popular is Pereira modification, where three transverse sutures are taken, and these are not through and through. These are not transfixion. These are just passing through the myometrium, but not entering the through the into the uterine cavity. And these are going laterally through the broad ligament through avascular area. One topmost is just below the cornu, then there is a middle transverse suture and lower suture, so that it also includes the uterine vessels. The suture also includes the uterine vessels also. And once these three transfers are taken, two are taken as vertical with piercing the myometrium just below the fundus at anterior part of the uterus. There is no piercing of the needle here at the lower end. That is how three transfers and two vertical, that is the Pereira's compression suture. Bhal's uterine compression suture is a where he has tried to reduce the number of points where the needle is being pierced. These are only two vertical mediolateral sutures. First needle passes through complete thickness, number one. But second, that is it is passing from anterior to posterior. Suture is going like that, posterior coming back anterior, and from number 2 point to number 3 point, it is piercing only the anterior uterine wall. It is not piercing through and through. And you are ligating the 3.3 and 6 with each other, and 1 and 4 with each other. So this is Ball's compression. For further, if you want to know the understanding, please go through the reference which I am going to mention at the end of the video. Husserl modification is modified Pereira, we can say, because there are only four transverse sutures. There is no vertical, and it is not transfixion suture. It is not going through and through the whole of the uterine wall and cavity. Quaba is where complete transfixation suturing of uterus is there, like that, two oblique, one middle transverse and one lower transverse. So this is his modification of this compression sutures. Outcome of compression sutures efficacy, which has been reported by various obstetricians, is 75 to 90% when it is used for uterine atony. Efficacy is greater when atonic PPH is there, but overall efficacy which is reported is 60 to 70%. Risk of uterine synecdoche formation is 5%, because we are entering into the uterine cavity opposing the anterior and posterior uterine wall with each other. Intrauterine synecdoche formation, yeah, that risk is 5%. And once this intrauterine synecdoche are produced, like Asherman syndrome, it can lead to amenorrhea or oligomenorrhea. So oligomenorrhea, infertility can occur, and if a patient presents like that, then we have to proceed with hysteroscopy and hysteroscopy directed management of this intrauterine synecdoche in around 5% of the cases. Uterine necrosis, pyometra are other reported complications with the compression sutures. No one technique of compression suture has been proven better than the other. Unfortunately, there are no RCTs, randomized control trials. It depends on the operator's choice or exposure to any given technique, whatever technique the person has learned. Depending on that, obstetrician will select not on the basis of the patient, and that is why there are no comparative randomized controlled trials are unfortunately not available. Summary of surgical procedures for PPH. We have vessel ligation, where now this is most important red part, hemodynamic instability. Any time when you are dealing with a case of PPH, it is an indication to directly proceed with hysterectomy. Hemodynamic instability, patient is going for hypotension, with a main there is a hemorrhagic shock features are there. In that case, hysterectomy is the better option rather than going with vessel ligation or compression sutures. Hemodynamically dynamically stable patient, you are doing giving medical management, you are starting with the IV fluids, crystalloid administration, blood transfusion is going on, patient is stable hemodynamically, then only we can think of uterine sparing procedures is the important concept, where either we can go with vessel ligation or compression sutures. In vessel ligation, we have uterine artery ligation, which can be unilateral or bilateral. It can be high ligation, low ligation. Triple ligation, where high ligation uterine artery is combined with the utero-ovarian ligament ligation and round ligament ligation. Stepwise devascularization. Number one is one-sided high ligation. Number two is opposite-sided high ligation. Number three step three is both-sided low ligation. Four is one-sided utero-ovarian ligation. Five is opposite-sided utero-ovarian ligation. Remember that 10 minutes wait is mandatory before we proceed with the next step. In comparison, we have B-Lynch sutures. Most popular at present are Cho sutures, square suture stitches. Heyman's modification of B-Lynch, so Heyman brace suture. Pereira, where three transverse and two vertical sutures are taken. Now, first three are transfixion sutures, where the suture or the needle passes through and through from one serosal surface, anterior serosal surface to posterior serosal surface of the uterus for B-Lynch, Cho, and Heyman. Pereira is where it is not passing completely. It is only going through the myometrium but not entering into the uterine cavity, with the hope that post-operative synecdoche formation as a complication, that complication will be prevented. Bhal brace, Hoson only 4 transverse, and Quaba, where as the diagram shows, 2 oblique, one in the midline transverse and one lower transverse. So conclusion, whether to go with compression or vessel ligation, first line surgical intervention is as per obstetrician's choice. We can go with vessel ligation or we can go with compression depending on our experience, whatever we have learned, whatever we can do quickly, whatever we are confident to proceed with as a surgeon, we can do first line. There is no such thing that vessel ligation is better than compression or compression is better than vessel ligation. Dynamically stable patient, then second line intervention can also be tried. Patient is stable, vessel ligation, persistence of bleeding, but patient is hemodynamically stable, we can go with the second line as compression. Or we have done compression as first line, patient is stable, we can go for vessel ligation as second line. Anytime patient is unstable, it is an indication to proceed with hysterectomy. Long-term complications are more with compression sutures, as we have already seen intrauterine synecdoche affecting the uh, fertility, chances of fertility or leading to oligomenorrhea are more with the compression sutures as compared to vessel ligation, and that is why some of the uh, these obstetricians or some of the guidelines are also selecting vessel ligation over compression sutures. Or what I think personally is atonic postpartum hemorrhage, compression sutures are very effective. But if there is a cesarean section scar extension leading to profuse intraoperative bleeding, then vessel ligation is better. Uterine artery ligation is better. Internal iliac artery ligation is technically more difficult than uterine artery ligation or stepwise devascularization and compression sutures. Technically, it is more difficult, and so it is again the operator's choice whether to add this as step. If patient is stable and still vessel ligation also is not effective, we can then try in that case This obstetrician is confident, can go ahead with internal iliac artery ligation, provided patient is hemodynamically stable before taking a decision for hysterectomy. Thank you so much. This is the most important reference. I want all of you to go through this reference yourself. I will be providing this link in the description box so that you if you originally go through this article, see the diagrams, see the pictures, you will get a better idea. It has this article 2024 article on uterine sparing surgical procedures to control PPH has helped me a lot in preparing this presentation because it gives the evidence based opinion about the various types of surgical procedures where we can do uterine sparing surgery for control of postpartum hemorrhage. I have also gone through Williams Obstetrics and Area's Practical Guide to High Risk Pregnancy and Delivery 2020, Green Top Guideline 2016, and FIGO Guideline 2020. Thank you so much. Do give me your feedback so that I know whether it is the presentation is helping you or not. Thank you once again.